The first thing that I consider with the patients and their body parts that we're taking radiographs of, start with thickness, okay? How thick is the body part, okay? Now, usually what you'll have, you might not always have this exactly, but usually what you'll have is a technique chart like this, and it'll give you, for some exam, PA chest, it'll give you a KV, a recommended mass, okay? That KV and recommended mass will be for your average sized patient, okay? So then you kind of need to know what average size is. When you measure them, you compare the measurement you get to the average size, and you either adjust up or adjust down to account for that. We'll use the device called the caliper to take care of that. Now the important thing about calipers is they measure in inches and centimeters. We'll usually take the centimeter measurement because we have a 4 centimeter rule, not a 1 inch rule, right? And so we measure in centimeters, and we take a thickness, and we make sure we measure at the thickest part of that body part. Okay, so if it's the chest, you measure right at the nipple line. Okay, if it's the lumbar spine, you measure right at the umbilicus, right at the thickest part of the body, the area that you're radiographing. Make sure when you do this that you don't squeeze the caliper. Also, we typically like this to be done when the patient's standing, because once we lay down, we tend to flatten a little bit, okay? So we want to take a true thickness measurement, and the calipers do that. Now, if your patient's laying down on the table, make sure this fixed, oh, you can't see my mouse. Make sure this fixed part of the caliper is what's touching the table, and let the movable arm part of the caliper settle down onto your patient, if you're doing it with the patient supine. If you're doing it standing, it doesn't really matter, as long as you don't squeeze the calipers. Here are some average thicknesses. Let's take a look through some of these. I'm not going to cover all of these because there's a lot here. You should refer to this periodically just to kind of train your brain on what average thicknesses are. Let's look at a couple of these here.
Centimeters, right?
This is in centimeters, yeah. So average thickness in the adult. So this is important. This is adult in centimeters. And this over here is the percentage frequency of people falling within the average, okay? So let's take a look. So for example, the hand, okay? The hand has an average thickness of 3 to 5 centimeters, okay? And 99% of people have a hand that's 3 to 5 centimeters thick. That means out of 100 people that you'll radiograph, 99 of them, if you measure their hand, it's going to be 3 to 5 centimeters thick, and one of them is going to have a hand that's thinner or thicker than that. Okay, if they're very large or very small. What that roughly translates to is whatever the mass setting, let's find hand on here, 56 kV 3 mass, right? 56 kV and 3 mass should be the mass setting for everybody's hand, right? Only one person out of 100, you should use a different mass setting for them, okay? Everyone comes in, gets the same technical factors for their hands because everyone's hands are the same size, okay? Difference of 3 to 5, if I'm 3 centimeters thick or 5 centimeters thick, I'm going to use the same factors, okay, roughly speaking. So everyone gets the same factors for a hand. That's why hands and wrists and feet and ankles are easy to remember, because if you look, hands and wrists, let's look at the wrist, right? 99% of people have a 3 to 6 centimeter wrist, okay? Go down here to the foot, right? 6 to 8 centimeters, 92% of the population has a 6 to 8 centimeter thick foot.
So, I'm x-raying somebody and their hand is like the thickness of my pinky, which is considerably less.
Yeah.
So I'm going to just lower my mass a little bit.
Yeah.
And just
leave KB alone.
A little bit.
Knock the mass down 50%, a minimum of 30%. I think the book says 35, but a minimum of 30%, right? More like 50%. You lower the mass for that.
Just a little bit.
For that one patient out of 100.
Right? My guy just pushes the button and just.
Yeah. So you come in, their hands as thick as your pinky finger. Measure it, right? Measure how thick. It's thinner than the average, but measure it, right? And then drop your factors accordingly.
Yes.
Okay.
That's about it.
Good. And so you see that, right? Here's where you notice, like, all of these, for the most part, have minimal variance. Like, a lot of people, like, even like a knee, 10 to 13 centimeters, and 92% of people have 10 to 13 centimeter thick knees. 92% of adults, at least. But
so
go ahead.
Well, these are averages, but are we averaging off of body, weight, or like.
This is taking entire populations and taking an average a measurement of all of them and getting an average from it.
It's including that, but we don't go, you're a big boy, so we're gonna do this. We don't look at it that way.
No,
we
so
look at it just from the percentage.
You know, so you think about if they're, you know, stenic, right, average body size,
Yeah.
you know, their hand's gonna be 3 to 5 centimeters thick. If
Right.
they're 400 pounds, their hand is still likely to be 3 to 5 centimeters thick. You know, a little bit of extra, you know,
For the hand,
they
right.
should still fall within that because hands don't get morbidly obese like the rest of the body does. Now, to extremes, yeah, but that's the 1 out of 100, right?
Or the 0.5.
Exactly.
The 0.5%.
Exactly. So yeah, you'll get those
Okay.
extremes for sure.
All right.
The important thing though is that when you look down in these different parts of the parts of the body that tend to change in size drastically. Most people's hands are similarly sized. You know, how many glove sizes do you find at the store? 3. Small, medium, large, maybe extra. Let's call it small, medium, and large just to make it simple, right?
I find that.
3 or 4. Okay. How many pant sizes do you find at the store? More than 3 or 4?
Oh, yeah.
Yeah, because we all wear a different pant size, right? And many different pant sizes because there's a wider range of buttock and thigh and leg lengths and sizes, right? We vary much more in our other parts of the body than we do in areas like our hands and wrists, yeah? That's why there's 3 or 4 sizes for gloves, but like a dozen or more sizes for pants. I'm guessing at a number, but it's more than 3 or 4. So if you look down at like pelvis, for example, the average pelvis is 19 to 23 centimeters thick, but only 78% of the population falls into that average category. That means, you know, roughly a quarter of people are bigger or smaller than that, okay? Because we vary widely in these areas where we tend to put on adipose tissue and musculature. Okay, and you see that for these different body parts. Let's look at maybe a different one. Cervical spine, right? AP cervical spine, average thickness, this is up high, 12 to 14 centimeters, and 77% of the population falls into that category. So you're going to find a wider variance of thicknesses up here because people have different sized necks, okay? So that's the idea. One thing that often gets asked on tests, because it's hard to remember all of this, you're often asked about the average torso thickness, okay? So this is something you should remember. 22 centimeters front to back is average, 30 centimeters lateral, so 22 by 30 is the average torso thickness. Chest x-rays are a big chunk of what you do, and you know, so torso thickness is important. Yeah, so if your technique chart says 120 kV and 5 mass for a PA chest x-ray, they're saying that for the 22 by 30 centimeter patient, okay? If the patient measures 26 centimeters A to P, then you go to 10 mass, okay? So you're measuring against the average person. And I was just using a rule called the 4 centimeter rule, one of the questions I asked you guys earlier. Is everyone okay with the 4 centimeter rule? Because I'm just not going to spend time on it if you guys are feeling okay about it. All right, good. Moving on. And I am jumping around a little bit. Just keep in mind if you're following along, you can track by looking at the slide number that I'm on. So I'm going to talk about tissues now. So now, ignoring thickness, I can have a body part, 2 body parts that are equally thick, but because they're made of different organs, they will have different densities. You know, my chest is similarly thick to my abdomen, right? But my abdomen is so much denser because my chest has mostly airspace, you know? So we have to talk a little bit about molecular composition of tissues and contrast agents. So the thing to take away from this is, roughly speaking, on an X-ray, on a radiograph, you will only be able to demonstrate 4 different natural tissue types, and 5 if you include any contrast agents, any prosthetics, or any other metal artifacts in the body. So metals are the 5th category, or in this case, the first one. So we can see, in order of density, metal, densest thing that we can see, bone, soft tissue, fat, and gas. So when I think about it, I think bone, muscle, fat, and gas. Okay, so when they say soft tissue, I'm thinking muscle. Muscles, muscle is, we'll say blood-filled, right? And blood is at least 51% water, so it's liquid. It's making the density here. It's denser, right, because of the water. It's the liquid, it's the fluid that adds the density. Yeah. Good. You know, the lungs are made of connective tissue. Okay. So is muscle. Muscle is also a type of connective tissue. The difference in density is due to the muscles filled with watery blood, and lungs are filled with airspace. Good. So, and when we say gas, we mean air. So air in the lungs, we mean literally gases in the intestines, right? From the digestive processes. So gas can mean air. It can mean other gaseous substances in the body. We don't mean gasoline. We mean gas, like things that are in the gaseous form. Okay, good. Questions there? 5 different densities that we can determine. So how should we think about how these should appear? So in a balanced image, things that have optimal contrast, soft tissues appear as a medium gray, fat being darker, gases being darker than fat. Importantly, nothing within the body should be perfectly black. Okay, even the lungs on a chest x-ray are not perfectly black. We see some grayscale within the lung. Okay, if any structure within the anatomy is completely black, then that has been overexposed. Okay, to use our correct terminology, what we mean is any anatomy that's demonstrated overly dense will be completely blacked out. Okay, radiographic density. Yeah.
And we're not talking about the IR that's not covered by tissue. We're talking about the tissue specifically.
Absolutely.
So the IR, where the body is not, should be your black. Should be your dark.
Absolutely. Yeah.
And we're assuming that.
Yeah, because there's no body there, and if the beam is hitting that part of the receptor with no body there, it's going to be black. Yeah. So you see that sort of here, right? At the edges, the periphery of this abdominal radiograph, it's completely black, right? The edges, the abdomen takes up most of the width of this, but the edges are completely blacked out. Outside of the anatomy, that's okay. Okay, so that's what Michael was getting at. Outside of the anatomy, that's fine. Within the anatomy, nothing should be perfectly black. Okay, if it is, you've over-penetrated the patient. Okay, let's go to the next thing. So the 2 things you've learned so far is you've learned that there's a part thickness and there's averages for these thicknesses, and a certain percentage of populations fall into those averages. Smaller body parts tend to have higher percentages of the people within the average. Bigger body parts tend to vary more widely. You've also learned that body parts are different in density. Okay, as we get back into the category module, which we didn't get out of too long ago, but the modules of the chest, extremities, and torsoskeletal, we'll talk more about those actual tissues that we're going to be going through. But that's the idea: is that there's different tissues. We can demonstrate roughly 5 different tissue densities on a radiograph. So the next thing to do is talk a little bit about pathology. Okay, what do we mean by pathology? What's the word mean? Study of disease. Pathos means disease, right? So study of disease. So pathologies are disease processes that we know about in the patient, either from good history, either we have medical history on them, or we've taken a verbal history from the patient, or we've gotten some information from the physician based on their objective exam on the patient. They listen to the lungs and say, upon auscultation, I heard rowels in the lungs, right? Rowels are crackling in the lungs, but from fluid being in the lungs. The physician heard rowels in the right lung base, and we can infer that the right lung base is going to have fluid in it. Okay, fluid's denser than air, so now we know the patient has a pathology that's changed the density of their lung. Okay.
And that would be something like pneumonia?
Pneumonia would be an example, yeah. And the opposite of that would be patient comes in, so I'm thinking chest right now. Patient comes in, physician does their little auscultation exam, they listen to the lungs. I heard no lung sides on the left side of the chest. Okay, no lungs. I might have said signs. Sorry, sounds. No lung sounds on the left side of the chest. Okay, that really only comes from a collapsing lung, right? A pneumothorax. Well, a collapsing lung is there's a lung and now it's taking up less space. So now there's a bunch of more air space where lung used to be. Okay, open empty space in the thorax. That's taking away density. Okay, that is a subtractive condition. So we have to consider the patient's pathologies and if we should change our exposure factors to account for these pathologies. That's the idea. We have to change technique to account for pathology, just like you had to change technique to account for thickness and density. Okay. Let's talk about these just a little bit here. So the classifications are going to be either there are additive diseases that add density, either because a body part is filling with blood or fluid or something like that, sometimes due to trauma. Somebody rolls their ankle and they come in with a big giant swollen up ankle. That's blood filling the in and around that joint space, edema or the hematoma, whatever, the ecchymosis. There's blood in and around that joint space, and that's going to add density. You have to consider that when you take your radiograph. Additive diseases increase the density. They make them more radio opaque. Destructive or subtractive diseases take away density. Osteoporosis. Not brittle bone disease, sorry. Osteoporosis is a loss of bone density, usually as we age. And so I just said loss of bone density. There's a tissue in the body, bone, and it's less dense now because we've lost density. Okay, that's a destructive disease. Roughly speaking, for additive diseases, technique change can range from the minimum change of 35% all the way to like doubling, 100% increases. And it really just depends. So this is going to come from a lot of trial and error. Okay, you're going to have to rely on what the techs have experienced in the past, and different X-ray processors are going to respond differently to pathologies. Some might be highly sensitive to the pathology, and whatever factors which would have worked for the average person just won't fly for the person with pneumonia, right? But others will be able to work with you, right? Others will be adaptive to it and be able to actually account for that without you having to change much. So. And there are many. I want to bring up the slide for additive and then the slide for destructive and just talk about a couple of them, not all of them because there's just too many to talk about. But let's go to like what do we got? Let's do this one. Ascites. Ascites is fluid in the peritoneal cavity. Okay, they get these big swollen up fluid-filled abdomens because of lots of different reasons. Sometimes due to like organ failures, other times due to perforations in places, but there's fluid in the abdomen, okay? Fluid in the abdomen, increase mass 50 to 75%, okay, because of the extra fluid there. Let's look at cardiomegaly. Cardiomegaly, what's cardiomegaly?
Enlarged heart.
Enlarged heart, good. Increase mass 50%, okay? Their heart is now bigger, taking up more of their chest in a chest x-ray. Go up 50% in your mass. You were using 5, now use 7.5. Okay. Let's see, what do we got? Any of these other ones that are good? Pulmonary edema. You are the X-ray tech at the base camp of Mount Everest, right? And all of your climbers have pulmonary edema because they're at high altitude. Okay. Add 50% to your mass. You can also get pulmonary edema from not climbing Mount Everest because you've got like congestive heart failure and stuff like that too. I was just giving a funny example. Let's look at a couple others of these. What do we got? Here we go. Osteopetrosis. Osteopetrosis is the opposite of osteoporosis.
Too much.
So increase in bone density. Yeah. Good. Add 8 to 12% kV. So you can do these with mass changes, you can do these with kV changes, you can make the beam just more penetrating for a denser body part. Alternatively, you can raise the mass, to just give more x-rays in the beam. An 8 to 12% kV increase is roughly equivalent to like a 50 to 75% mass increase, roughly speaking. So those two things are sort of the same thing. Let's take a look at some of the destructive conditions. Aseptic necrosis. This is tissue death. Okay, so necrosis tells us we mean tissue death. That's taking away density to the tissue. It's destroying tissue. So drop the kV by 8%. That's similar to saying lower the mass by 25 to roughly 50% in that neighborhood. Emphysema. Emphysema is the smoker's disease. Trapped air in the lungs causes the lungs to hyperinflate. So now the lung volume, which was one volume, is now a bigger volume. Okay, so the tissue is now more spread out. It's now less dense. So we're going to lower our kilovoltage a little. Yeah.
Why is a bowel obstruction a destructive disease?
So it's not the obstruction that's the destructive part of this. It's think subtractive, but anyways, it's not the actual obstruction, because the obstruction's like a poo, right? Yeah. But the poo is going to cause a backup of gas, and the gas is going to hyperinflate the intestines. Okay. Yeah, you're thinking the right stuff though. Let's just do like maybe two more. Let's go with osteoporosis, which is the loss of bone density. Come down in kV, 8%, or drop mass 25-50%, something like that. Lastly, pneumothorax, 8% drop in kV. Notice, have you paid attention to what these all are? These are all the same recommended decrease, okay? So you don't have to remember a different recommended decrease for these different conditions, just roughly speaking, 8% down in kV, or about 25-ish to 50-ish% mass. The reason why I'm saying ish and about and waving my hands around is because it's just different for every patient, okay? You can have two patients with a pneumothorax. One could be a pneumothorax that's a millimeter away from the lung wall, okay? It's teeny tiny, okay? Their lung has barely collapsed at all because it just happened, okay? Or you could have a tension pneumothorax where the lung has completely collapsed and is pushed up against the hilum and is dragging the trachea over to the opposite side of the body, putting the trachea under tension. That lung is completely collapsed, and that's a different condition than the lung beginning to collapse, right? So those two things aren't the same, but they both are put into the category of a pneumothorax. Okay. Good. I want to talk lastly about sort of post-trauma, okay? Post-trauma, patients are often casted or splinted, okay? They have a metal splint, right? Aluminum splint usually. They've got external or internal fixations, right? The rods and pins and all that, okay? But just regarding the actual splinting or casting material used to stabilize the body part, and again, that's the purpose of casts and splints, are to stabilize body parts, allow them to heal in a correct position. The adjustment of technique depends on a few things. For one, it depends on the type of material. Is it plaster or is it fiberglass? Is it aluminum or is it some other material, right? Plastic, not plaster, plastic, right? How thick is the cast or splint, right? How thick is the actual, on one side, how thick is the material, right? And then overall, how thick is it? Okay, so that's going to change things. Is it a whole cast or a partial cast? Is anybody familiar with orthoglass? Yeah? Abby, tell us something, and Lewis, maybe tell us something else.
It's like the netting of glass, and you measure the person.
And it wraps around, right? Lewis, what do you know about orthoglass?
It's kind of like a bandage in a way. They get to like wet,
Mm-hmm.
and then you wrap.
What's it made of?
Some type of fiber. How much?
Like some hard, thick.
Is it hard when it comes out of the package?
Like it'll harden up pretty fast if you don't.
So it's soft, right? It's in a roll, right? And then you pull it out, you cut the length that you need, and it's made of fiberglass, right? And then you mold it to the body part, and it hardens, right? It's the same density once it's hard, so the hardening is not important. But what is important is it is not a full cast, right? It's only on, let's say if you do a sugar tong type where it wraps around like this, right? It's only anterior and posterior. right? It's not on the lateral aspect. So you do the lateral image, and you're not having to punch through the splint, right? So depending on the type of cast, okay? And then with regard to plaster casts, wet or dry. Okay, so orthoglass, we wet it, but it dries very quick. There's no reason to take a radiograph of with the person in the orthoglass when it's still wet. It dries in 15 minutes. Okay, but plaster takes a long time, and we might want to know, as we're putting on this plaster cast. Plaster is great, by the way, because it's highly moldable to the patient. It's super cheap, but it's really messy. Okay, orthoglass is not messy, less moldable, but very expensive. Okay, it's just easier to use. We might want to know after we mold the patient in a fiberglass or in the plaster cast. Let's radiograph it. Let's make sure that they're in the right position. That way, if we have to take it off and start over again, or bend the mold a little bit, we can do it while it's still wet and pliable. Okay, so wet or dry. Obviously, wet is liquid, and the liquid's going to add density. Any radiographs we take after, usually what we think of these as immediately after the casting or splinting, we call them post-reduction. Okay, so think about someone dislocating a shoulder or a finger, right? It's dislocated, it's out of its location, and then we relocate it. We call that reducing it. Okay, reducing a dislocation is called reduction, and so the radiographs taken after the reduction are called post-reduction. And you might want to do that with the casting on. Sometimes we do it with no casting or splinting on, but maybe they've been casted or splinted because it's an unstable type of injury. So let's give some numbers to this here. So let's think thick and wet plaster. 4 times the mass or 30% the kV, 30% increase in kV. So 5 mass goes to 20 mass. Medium thick and wet plaster, 3 times the mass. So you're seeing less mass increase for medium thickness, still wet. If it's thick and dry, treat it like a mediumly thick and wet one, wet cast. So these both have the same. Mediumly thick, so not super duper thick plaster, but dry, so medium and dry, double the mass. For mostly, these are for plaster, by the way, because a fiberglass doesn't change, you don't need to change much. But if you look at plaster half casts, dry fiberglass plaster full casts, plastic splints, or wood splints, 50% mass increase or 8% kV increase. And anything that's fiberglass or anything that's inflatable, air splints, things like that, no metal in them, nothing. Don't change anything. Fiberglass is not dense at all. Doesn't change much. And it's not thick either. I mean, if you've had the orthoglass in your hand, it's the actual thickness of the material. It might be wide, right? It has different widths, but the actual thickness of the material is millimeters thick. Okay. Let me go ahead and move on. Make it good time.